just talked about how non-disjunction is going to lead to gametes with an abnormal number of chromosomes. So this gamete, remember, meiosis, we're going to end up with a gamete with one set of chromosomes, so 23 chromosomes total. And that's going to meet up with another gamete that has its own 23 sets of chromosomes, totaling 46. So somebody with a non-disjunction event in their history, that offspring may end up with an abnormal number of chromosomes, and we call that aneuploidy. I'm not entirely sure of the pronunciation there, by the way. If it's a Germanic basis, then that's pronounced noi right there. That's what I'm assuming. I don't think I've ever heard this pronounced in the real world. What's that? Have you heard it otherwise? Aneuploidy? That probably does sound better. I like it. Yeah. Whatever. I prefer Germanic because it's annoying. No. So yeah, ignore my pronunciation on that one. It just means there was a non-disjunction event, and that could go in any direction. So that's the general term for there's an abnormal number of chromosomes, more or less than 46. If you have one fewer chromosomes than you're supposed to, instead of 2, you have 1, that's a monosomy. If you have more than 2, that's a polysomy. So typically, for most cases, a monosomy is not going to be compatible with life. When women have miscarriages, which is unbelievably common, that most likely is a chromosomal abnormality or a genetic abnormality. Those are the most common causes for miscarriages, yeah. Yeah. It's simply not going to make it's not going to make a fetus. It's not going to make a functioning embryo. It's not going to make a functioning fetus. It's not going to make a functioning baby for most monosomies. It's brutal, but that's the cause for most of them. Or genetic disorders that are not based on aneuploidy, something like that. I'll work on pronunciation. Okay, polysomies, it depends on which chromosome, right? We are going to see one monosomy where that can be a person and an adult, but most of them will not be. Polysomies, we will see a few cases of polysomies that result in a viable fetus. Most of them are going to lead to severe disability of some kind or another. If it's a sex chromosome, those tend to be not as debilitating. So maybe you were taught in like high school biology, there's XX and there's XY and there's nothing else, and that was a complete lie. Yeah, and that was just the beginning of the lie. We'll get more into that lie later. So again, a lot of chromosomal abnormalities, they're poorly understood, but we think this non-disjunction event happened because there was some kind of toxin, radiation, virus, chemical exposure that led to that non-disjunction event. And that actually really follows very well with this idea that risk factors include in advanced maternal age, women sitting along for a lot longer, accumulating radiation, accumulating viral exposure, and then abnormalities in parental genetic structure. That just means there's a genetic disorder that also plays into the way meiosis happens. So the most famous trisomy, the most famous polysomy is a trisomy. That means there's 3 copies of chromosome, in this case number 21, that's Down syndrome. Trisomy 21 is Down syndrome. And the reason it's the most famous and the most commonly known is this one is the one that's technically the most likely to lead to a viable fetus and most likely to be born and most likely to live to an age that is visible in the population, right? A lot of fetuses that are identified to have Down syndrome, they may be stillborn, they may be aborted because we do have prenatal testing to determine that. And yeah, there's big ethical implications there. We could have some major discussions about it if we want to. It's not an abortion discussion class though, so we're going to skip right over that. Let's see, here's our sort of chart of some of the things that can go with Down syndrome. Aside from like protruding tongue and some of the physiological differences, there are some health issues associated with trisomy 21, including congenital heart defects, intestinal stenosis, which means like a narrow portion of intestine, predisposition to a number of other health issues, such as leukemia. Now, as our general medicine improves, quality of life, length of life is extending all of the time for individuals with Down syndrome. And we've got people living to a ripe old age with Down syndrome these days. It's highly variable, and it's very much based on access to health care. So there's definitely socioeconomic status that plays into this. But yeah, somebody with Down syndrome, depending on their support, depending on the systems that are in place for them and access, can lead a fairly full life at this point. Yes, a pretty full life. That's a very good question. Not necessarily, as I understand it. There are going to be some commonalities, and as always, there's always a continuum of how big of an impact there is. There's always people who are going to be having more or less severity for each of these. Have you seen the woman with Down syndrome whose goal in life is to be a model? She's adorable. I love her. Let's do the thing. I don't know if I'm sharing my screen anymore. I am. Drum model. Her. She's adorable. Look at that sweetheart. Love her. Okay, so let's go ahead and go back to lecture. So even phenotype is highly variable, right? And then again, it's a predisposition to leukemia. That doesn't necessarily mean they're getting leukemia. So that's the really famous, well-known one. There are other trisomies, and their rarity is mostly about like how many of them actually survived to be born. How many of these happened but were miscarriages? We don't always know, because we don't always find out what caused a miscarriage. I know that's a big scary word, and I'm just tossing it out there, and it's somewhat intentional because it is so common. That we know of, 25% of pregnancies in the first 12 weeks results in miscarriage. That we know of, and it's probably higher just for fertilized eggs that don't even implant, that are just flushed out during menses, just because of the way that fertilization, implantation, and pregnancy occur. So I do really want to normalize that idea a little bit, even though it's harsh. So you can have a trisomy of the 18th chromosome, and that would be called Edwards syndrome. There can be a trisomy of the 13th chromosome, and that would be Patau syndrome. Those are much less common, and they do tend to be more severe. I have seen pictures of adults with Edwards syndrome, or at least with Patau syndrome. I can't remember which one. It's possible. It's just not very probable. And then trisomies 8, 9, and 22 are extremely rare in the population in terms of how many of them will be a viable fetus. Our sex chromosome disorders tend to be more survivable. They're going to be more likely to survive to an older age. So these are going to be polysomies, or in one case a monosomy, of sex chromosomes. So Klinefelter is XXY. Klinefelter is always XXY. So the person is going to be born phenotypically male. We're going to see a male baby on the surface, unless we do genetic testing and determine that there's an XXY. Around the time of puberty, however, they're going to develop some phenotypically female characteristics, a female fat distribution, for example. There's going to be a lack of secondary sexual characteristics. There's going to be no facial hair. Yeah, that extra X chromosome sort of enacting some feminizing traits, essentially. For a lot of these sex chromosome things, there's going to be issues with fertility. Yeah, decreased fertility or sterility, depending on which one. Turner syndrome is a monosomy of the X chromosome. It is only one X chromosome, therefore phenotypically they will be born female. This person will be short in stature. No ovaries are very fibrous ovaries. I think your book is oversimplifying the ovary situation. There's a short stature, there's a webbed neck, fibrous ovaries, sterility, absence of menstruation, that's amenorrhea. So we're talking about the sort of physical outward characteristics, but the congenital heart defects is what we're really worrying about in terms of their health and lifespan. Yeah. Yeah, they're not going to be like functional gamete producing ovaries. We may be able to, you know, on autopsy find something that resembles an ovary. But as I understand it, somebody with Turner's may have a very, very brief window of fertility in their life when they're very, very young, and then it's over. There's a really terrible and inaccurate Law and Order SVU episode about this. Has anybody seen it? Yeah, they just have like a cute little girl, and she's like, I have Turner syndrome, and she's actually 20, but she looks like she's 12. So it gets into this like legal issue of, yeah, but it's really medically inaccurate in every which way, and it's not to be trusted. Don't trust SVU. As much as I love that show. Yeah, Law and Order SVU doesn't understand hymens either, so I'm glad. Yeah. They don't check it for rape, or they do, but it's not like a valid for trauma. Yeah, they'll check the area for bruises entirely. It's just a misunderstanding. Nobody knows what the hymen is. Once we're off the recording, if you want, we can watch that video. But we're recording right now, and people are going to be listening to this for years. So. Okay. So now we're out of the aneuploidies. I'll change my pronunciation now, I promise. I like to know. Okay. We're going to move on to single gene disorders. I did go, when I restructured things, I went and I collected genetic disorders from other systems. And in doing so, in some cases, I removed them from future lectures. So for example, like a genetic disorder that's of the respiratory system is brought here, and we will not cover it again when we get to respiratory. Or there's one that's digestive, that's the liver. There's two that's digestive and liver, but they're genetic based. We do not cover those during digestive lecture. There's actually kind of like a little gap in that lecture where they should be, and it drives me crazy. So I just want to point that out, that they'll actually make sense in terms of the fallout once we get to that system-based approach later on. We're just not to that system-based approach yet. So I tried to bring all the genetic disorders in. So again, they can be autosomal dominant, autosomal recessive, or X-linked as a disorder. Marfan syndrome I've already brought up today. It's a connective tissue disorder. Again, genome determines proteome. What if you're missing the blueprint for some of your collagen fibers, some of your connective tissue fibers, some of the things that literally hold you together and are the fillers and the glue holding like anything in between layers together. So think of like the tunics of your eye, the tunics of your blood vessels. Think of the connective tissue in your tendons and your ligaments. And then that's going to give you the fallout for Marfan syndrome. So again, it's not really a syndrome. We know exactly what it is. It's a genetic disorder that affects connective tissue, and connective tissue is everywhere. So somebody with Marfan syndrome, the phenotype is going to be a very, very tall and skinny person. In fact, any very tall and skinny person is going to be at risk for some of these issues that we're about to look at, even if they're not diagnosed with Marfan syndrome. Now, the person that we have on this next slide here, that's pretty extreme. We're not necessarily going to have that level of spinal deformity in a person with Marfan syndrome. So that's the phenotype. The idea is while you're growing, your ligaments are holding your bones together and actually sort of limiting your growth. So without that connective tissue limitation and that hypermobility of your joints, you grow very tall during the growth process. It's just a very literal process at that point. Arachnodactyly is just about your fingers being able to like cross over on the other side of your wrist, very skinny wrists and very long fingers. I think I've got a picture of that coming up. So what we worry about with somebody with Marfan's is all of the things that go with connective tissue problems, cardiovascular lesions, like what we call a dissection. Somebody could have an aortic dissection, which means the layers of their aorta have peeled away from each other, and a bunch of blood rushes in between those spaces. Yeah, and that's a really big problem. If an aortic, not an aneurysm, if an aortic dissection occurs, their blood pressure is going to drop as they lose their blood in between those walls. That person's going to keel over, and that's a cardiovascular emergency. They need surgery immediately. So that's the most immediately life-threatening, but there's a lot of things that can happen with connective tissue that are not immediately life-threatening. You could spontaneously collapse a lung. You could have a retinal detachment all of a sudden. There's going to be a lot of pain associated with that joint mobility that goes with having unstable joints. So really everything is impacted. Another really debilitating one is Huntington's, also autosomal dominant, which means that it does tend to run in families every generation. It's very likely to pass on to offspring. The thing is that symptoms usually appear after the age of 40. So people do reach an age of sexual maturity, and if they know that they have Huntington's or that they have the gene for Huntington's, then they get to make a decision whether they want to pass on their genes or not, presumably, right? And that can be a tough decision. So Huntington's disease is going to be something that wastes the brain away. We'll talk about this again during our neurological lecture, our neurology stuff. It's especially going to impact the basal ganglia. Does anybody remember what the basal ganglia do? Also known as cerebral nuclei, according to your AMP1 textbook. Not balanced, but I think you've got a keyword in there that brought up the way I tried to teach it to you. It is a movement thing. Kind of. We're still in the right ballpark here. No, but you guys are skirting around the idea really well. So what it is it's not too much or not too little movement. It's when you don't want to be moving, you're not moving. When you do want to be moving, you can initiate movement. That's what your basal ganglia do. There's a positive and a negative pathway that inhibit and excite respectively, which you will need to know more about as we go through pathophysiology as you go into pharm, because it's a dopamine pathway and you're going to need to know about dopaminergic drugs and Parkinson's disease and all this other stuff. So your basal ganglia are going to degrade in Huntington's disease. Your brain as a total is, but it's going to impact the basal ganglia first. And a big sign of this is unwanted movement. There's this thing called Huntington's chorea, which just translates to dance of Huntington's, where somebody, especially on one side more than the other, has a lot of unwanted movement, including like very big, exaggerated movements. It's related, but no.
It's like wider.
It is much wider, yeah. And it starts small and then it gets really big.
Yeah.
And I'm going to pause this. So again, we will see Huntington's again during our physical brain week. We have a physical brain week and we have a mental brain week. We have a psychological disorders brain week. And it's 2 different weeks. Okay, here's a fun one to say. Hereditary hemorrhagic telangiectasia. Good one, right? Also known as, also really easy to say, Osler-Weber-Rendu disease. Take your pick. It's autosomal dominant, and it's going to be a disorder of small blood vessels. They are dilated, they're tortuous, they bleed very easily, and you're going to have a lot of signs like this of widespread hemorrhage. Anytime you see these little pinpoint pricks of blood, that's a sign of widespread hemorrhaging. That's not good. I'm not sure. I don't know enough about this one. Hemophilia is the most common inherited coagulation disorder, and it's not one disorder. There's a variety of hemophilias. If, for example, you were to put hemophilia in the discussion board, I would say, which hemophilia? And then you would isolate it to there. All of these are going to be, at least all the ones we're going to look at, are going to be factor deficiencies. So hopefully back in blood lecture, we talked about the clotting cascade. I didn't hold you to learning every single part of the clotting cascade in order. You didn't have to learn that whole pathway of factor 7 comes in, then factor 9, then factor 11 comes in, then factor 10 comes in. We didn't have to do that, but you did have to understand that there are different factors, different proteins, different enzymes in a cascade that ultimately lead to clotting, right? Let's ring a bell. Everyone's good on that? Good. So what this is saying is that genetically, you could be lacking any one of those factors, and any one of those factors can lead to a problem with clotting. And there will be variable degrees of severity in here. That's about it. All of these are going to interrupt the clotting cascade at the most fundamental level. So hemophilia A is a deficiency of factor 7. Hemophilia B is also known as Christmas disease, is a factor 9 deficiency. And people have asked before, do we mean Christmas like the time of year? Apparently we're talking about the Christmas Islands, according to Wikipedia. Don't quote me on that. Let's see. I just duplicated that. That's really weird. Okay. It just says the same thing twice. I was like, what did I do? Ignore that. Von Willebrand is also factor 8 and also platelet dysfunction. So all of these are going to cause excessive bleeding. We will have more discussions about blood, I think, next week. I'm saying everything's next week. It's because I don't quite remember where I put things when I rearranged them. We'll figure it out. There's going to be a lot of things that go along with clotting disorders. I think the one that I have on here is hemarthrosis, and that means bleeding into a joint. And there will be a picture for this later on when we get to blood, where you're going to see like a person, they've got both of their legs exposed, and then this knee joint is just out here, and it's just the blood is going that joint. The nice thing about humans is that we're bilaterally symmetrical, so you can always compare a right versus a left and see which one is going to be normal, have a normal to compare it to. Okay, muscular dystrophy. These are the ones that I think I took out of musculoskeletal, where I'm just like, where did my dystrophy go? Okay, so some forms of muscular dystrophy are, I'm going to rephrase that. I actually don't have every form of muscular dystrophy here. I only have Becker's, and wait for it, facioscapulohumeral muscular dystrophy. Yeah, I can say words. It's my job. Okay, so these are both genetic. Give me just a second. What are you doing, friend? There you go. Let me check something here. Happens every once in a while. Yep, that happened. Sorry, guys. So fill this in on your notes, please. Sometimes when I copy and paste things, they get whited out, things that used to be blue. So Becker muscular dystrophy is a moderate form of muscular dystrophy. All of our muscular dystrophies, what we're saying is that there's a gene that codes for a dystrophin protein. Honestly, I think we discovered the disease before we discovered the protein and named the protein after the disease, because dystrophin's a really, really convenient name for a protein that leads to like a lack of growth in muscles, right? So all of your muscular dystrophies, these are about a lack of growth of muscles, a lack of stability of muscle cells. This dystrophin protein, what it does is it stabilizes the plasma membrane of your muscle cells. So if it's inadequate or absent, you're going to have different levels of stability in your muscle cells. So Becker muscular dystrophy is intermediate. The extreme form is Duchenne muscular dystrophy, but we won't see that until later. The stuff that filled in, I think it's on this line. Genetic mutation leads to production of a reduced amount of an abnormal dystrophin protein and slower muscular degeneration. Whatever among that was whited out. Yeah, and I think it's corrected on the one that's on your thing. It might just be the one on my computer, because sometimes I like correct it on here, but don't load it back onto my computer. Okay. The minor form of muscular dystrophy is FSH muscular dystrophy, if you don't want to say the whole word. And just like it says, it's going to impact mostly muscles of the face, scapula, and humerus, right? So it's going to be progressive and degenerative, and it's still going to impact quality of life. Somebody with FSH may not be able to smile, and that social communication is actually very important. You know, just people thinking you're a nice person. Like literally my dental assistant, I think she gave me all of that extra gunk to put in my dry socket yesterday because I was nice to her. I think she could have just thrown it away. I don't think it's normal to give it to people. So not being able to smile, I might not have gotten that special treatment, right? It's life altering. But most will live to a normal age. Now on to some recessive disorders. Again, this is mutation of an autosomal recessive gene, so you need 2 copies in order to actually express the disease. So being an albino, albinism is an autosomal recessive disorder that impacts melanin production in the skin. And the outcome for that is varied. Mostly it's about vulnerability to UV radiation. Somebody with albinism is going to be much more likely to develop a skin cancer, for example. So there are real health implications of that. PKU, phenylketonuria, PKU, if you want to be simple about it, is a metabolic issue. And again, metabolism is still based on the activity of proteins, enzymes breaking things up, or breaking things down, building things up. PKU is the inability to break down a specific amino acid, and then that's going to accumulate. And that one is very deadly. And of course, cystic fibrosis. Cystic fibrosis is a very common autosomal recessive disease. Here in Colorado, we've got National Jewish Hospital, which is pretty famous for its respiratory stuff. Said that very poorly, but whatever. So I've had lots of students. Does anybody work with CF patients in here? You work with CF? Anybody else? Okay. Not yet? No. So cystic fibrosis is a genetic disorder that mainly impacts, this is me collecting a couple of different slides from a couple of different lectures. That's why there's some overlap in here. It's a dysfunction of the CFTR gene, which codes for chloride channel, which you'll find in sweat glands, in lungs, and in the pancreas. And this one chloride ion channel is going to wreak havoc across multiple systems, predominantly in the lungs is where we're going to really focus our efforts. So we have a chloride ion channel. We're going to allow chloride, outside of the cell. In this case, the chloride is inside of the cell. What that leads to is an accumulation of mucus outside of the cell. And in this case, if we're in the lungs, we're saying there's mucus in the alveolar space. And when there's mucus in the alveoli, that's going to mean a few things. That's going to mean a thickened respiratory membrane, which means it's harder for gas exchange to take place. And what does bacteria do when there's like a lot of mucus and it's just stagnant? How's that going to go? It's just a great place for bacteria to thrive and grow. It's like a petri dish in your lungs at all times, right? You've got like a nutrient medium just hanging out for that bacteria. So that's really what cystic fibrosis is. At its core is your lungs are your petri dish and you can't breathe very well. You're going to be coughing up this mucus on a very regular basis. You're going to be prone to certain infections. And what's the rule for 2 patients with CF? What's the rule? You can't be with another person with CF because you're going to be carrying and prone to the exact same infections. So, exactly. If somebody ends up redoing a paper on CF, there's a lot more to it than that. There's even, since it's in the pancreas as well, some signs and symptoms that are close to diabetes. But we're going to focus on the lung stuff. We're going to save the more complicated stuff for MedSurg. Hereditary hemochromatosis and Wilson's disease. These are the liver ones that I yanked out of our digestive lecture. Again, this will make more sense when we've talked about the liver much more. But your liver is, among other things, a storage organ and a metabolic organ. So hereditary hemochromatosis means a genetic inability to break down or to control the flow of iron. You accumulate a whole bunch of iron from your diet, from things you've consumed, and instead of getting rid of that iron successfully, it accumulates, you deposit it wherever you can. In your skin, in your liver, in wherever it goes. Liver, pancreas, and heart. It can progress to hepatocellular carcinoma. That's going to be a cancer of the liver cells. And again, if we've got early diagnosis, there are treatments that can abate that. Wilson's disease is similar. It's also autosomal recessive. It's also related to a heavy metal. In this case, it is, where is it? I know it's in here somewhere, copper. So the other one was iron, this one's copper. Unable to get rid of copper successfully, accumulating copper, your body's just going to dump it wherever it can in a number of different organs, including the liver, and even sometimes around your iris. And yes, there was a House episode about this. Does anybody remember the House episode? And yes, there's psychological implications for having an overabundant copper as well. That one was decent. Not as bad as the SVU episode was. Okay. All right, any questions about that? Yeah, question, stretching? Okay, you're allowed. Anyone? Questions? It's making sense? Okay. Now I've got a little asterisk here. Congenital abnormalities. Well, I've got an asterisk because I'm not really going to address congenital things. I'm not going to address embryology until around week 5 or so. I actually shoved in a little mini embryology mini lecture right before we get into urinary and reproductive, which we do all in one day, by the way. So it's quite a bit of content that day. But this was in the interest of spacing out the pathophysiology and making today and week 2 a little bit less overwhelming. We won't really get to the causes of congenital stuff until much, much later. We'll address teratogens, environmental exposure during embryological developmental periods later on. So we're just going to say it's congenital and leave it at that for now. It just means you were born with it. That's all congenital means. So some of these congenital disorders are genetic disorders as well, but some congenital disorders are not based on a genetic issue. Some of them are exposure. Potentially, yeah. I mean, we do have those random genetic mutation events that can just occur for no known reason. We would call that idiopathic at that point. Yeah. Okay, so cystic kidney disease, also known as polycystic kidney disease, means the kidney is filled with cysts, and that's congenital in many cases. In humans, this is life-ending. In cats, it's not. I had a cat with polycystic kidney disease. I think that's hers, actually. That was my cat's kidney. So having a bunch of cysts where your kidney should be, it just means you don't have functional kidneys. It means you're probably going to need dialysis. And in a human, it's going to be deadly. They can also erupt, and that's going to be very bad too. That cystic kidney also may be enlarged in some cases. My cat was not. But yeah, it's not comfortable. Back to this idea of sex-linked disorders. I think we're just listing things at this point. And again, I wanted to show you that there's XX, there's XY. Just backing up that idea that it's much less likely to have a Y-linked disorder just by how much Y chromosome there actually is. And we already covered that. That's kind of a repetition, so sorry about that. And there's our muscular dystrophy, our Duchenne's muscular dystrophy. We covered the 2 other muscular dystrophies. This one's separated out because it's X-linked. The other 2 are autosomal. That's the only reason it's separated out. Duchenne's muscular dystrophy is the most severe form of muscular dystrophy. One pattern we're going to see in our muscular issues or our neuromuscular issues is it really gets deadly when it gets to the respiratory muscles. So there's actually a sort of like ascending pattern here. The initial weakness is in the lower extremities, and it kind of tends to ascend. And then later in like the 20s or 30s, that's when the respiratory muscles become weakened. And that's when we start having respiratory infections and issues with, this is low oxygen, hypoxia. Hypercapnia is elevated carbon dioxide level. And we will talk about carbon dioxide levels, don't you worry. That's going to be a thing. And there's that dystrophin protein. Here's the plasma membrane of a muscle cell. And here's a dystrophin protein, just connecting things, stabilizing things. So with all of these genetic disorders, our goal really is going to be during prenatal testing, prenatal diagnosis and counseling, is we're going to have plenty of genetic tests to determine if these things are present, and then that person will be counseled. So things like, there he goes, Ultrasound, amniocentesis, chorionic villus sample, embryoscopy. We have quite a bit of tools for detecting these things. And then it's not an ethics class, so we won't talk about what the outcomes of those discussions are. That's it. Okay, any questions before I turn off the recording?